So, in our talk about the posterior shoulder dislocation, we will start with an introduction. So, posterior shoulder dislocation is a complete posterior displacement of the humeral head out of the glenoid. And posterior shoulder dislocations are rare. They are accounting for less than 4% of all shoulder dislocations. And in comparison with the anterior shoulder dislocations, the anterior shoulder dislocations, they are accounting for up to 95%, being the most common dislocations occurring to the shoulder joint. Moving on to talk about the mechanism of injury. So, the at-risk position for the posterior shoulder dislocation is adduction and internal rotation of the arm. So, the at-risk position is internal rotation and adduction. So, the arm is close to the body and it is adducted to be at-risk position for the posterior shoulder dislocation. And an indirect force aggravating this position may lead to the posterior dislocation. Now, in comparison with the anterior shoulder dislocation, remember the at-risk position for the anterior shoulder dislocation is abduction and external rotation. Now, back to the posterior shoulder dislocation. So, the most common causes that lead to the at-risk position that we talked about and aggravated include during a seizure, and this is the most common cause. So the patient would have a seizure and they would have a dislocation during the seizure. Also, this could occur due to an electric shock or after a fall on the flexed adducted arm, meaning after a fall on the at-risk position and due to direct anterior blow to the shoulder, so a blow to the shoulder anteriorly, so this would push the humeral head backward and lead to dislocation, and also after a fall on the outstretched hand. Now let's talk about the clinical features. So the patient with posterior shoulder dislocation would present with shoulder pain and muscle spasm, and the arm is held in position of adduction and internal rotation. So the patient would hold their arm internally rotated and adducted, and it is supported by the other hand, and the patient is often comfortable in this position, and the front of the shoulder looks flat. The normal is rounded, so the shoulder is not rounded anymore. It looks flat and with a prominent coracoid process. Now remember, in anterior shoulder dislocation, the shoulder look flat but with the prominent acromion. Now in the posterior shoulder dislocation, the coracoid process would be prominent. And sometimes swelling will obscure the coracoid, but generally speaking, deformity is less dramatic than in anterior shoulder dislocation. Now this is an important point, that the patient will not be able to externally rotate their arm, and they also can't abduct their arm beyond 80 degrees. So when you do your orthopedic examination, focus on these points. So try to ask them to externally rotate their arm. If they can't, this would make the posterior shoulder dislocation more likely, and also ask them to abduct their arm. If they can't abduct it beyond 80 degrees, this would also make the posterior shoulder dislocation more likely. Now also inquire about the mechanism of injury to assess the severity of the injury and look for other injuries. And neurovascular examination is done looking for vascular and nerve injuries that is caused due to the dislocation. Now let's talk about the imaging in posterior shoulder dislocations. So the anterior posterior shoulder X-ray is ordered in these injuries, but it is unreliable because 50% of the posterior shoulder dislocations would look normal on the AB shoulder X-ray. So it is unreliable, but it is mostly ordered anyway, and it shows the light bulb sign. The light bulb sign is that the humeral head looks like a light bulb because the arm is in full internal rotation and the greater tuberosity contour is sitting in front now, so it is lost. Now this is better explained on the X-ray that you can see here. So the right X-ray is normal AB shoulder X-ray and the left one is for posterior shoulder dislocation. So on the normal AB shoulder X-ray, you can see that the greater tuberosity contour is present. As you can see right here, this is the greater tuberosity. The contour of this tuberosity is obvious, while in the posterior shoulder dislocation X-ray, because the arm is fully internally rotated, the greater tuberosity would be in front and it would not show in the border of the humeral head. So the contour of the greater tuberosity is lost on the posterior shoulder dislocation AP shoulder X-rays, as you can see in this picture here. And because of that, the humeral head would have no details in its borders, so it would have borders that look like a light bulb. So as you can see in this picture here, the humeral head looks like a light bulb in comparison with the normal humeral head, which has details in its borders and doesn't look like a light bulb. And that is what we call the light bulb sign. Now also in the posterior shoulder dislocation AP shoulder X-ray, you can see that the humeral head is located away from the glenoid, and that is what we call the empty glenoid sign. Now as you can see in the normal AP X-ray, so this is here is the glenoid and this is the humeral head, so the joint here is congruent, while in the posterior shoulder dislocation AP X-ray, you can see that the humeral head is located away from the glenoid and the joint is incongruent, so it lost its congruency. Now we mentioned that in the AP shoulder X-ray it is unreliable and 50% of the cases are missed on the AP shoulder X-ray, so it is important to have a high index of suspicion and order another view, specifically the lateral or axillary views, and both of those are diagnostic. They will show posterior displacement of the humeral head, which looks very obvious, and it will also show a reverse Hill-Sachs lesion, which is an anterior impaction fracture that may be obvious on the lateral view. So as you can see in this X-ray here, so this is an axillary view, and since we have the coracoid process here, so this is the anterior side and the other side is of course posterior. And here we have the glenoid, as you can see right here, and if we follow the humerus here, we would reach its head, which is located right here. This is the humeral head in this X-ray, and as you can see, it is displaced posteriorly. Now on the lateral view X-ray, you can also see the reverse Hill-Sachs lesion, which is an anterior impaction fracture of the humeral head. Now let's say that this hand is the humeral head and the other hand is the glenoid, and let's say that this side is the posterior side and this side is the anterior side, and when there is a posterior dislocation, the humeral head would be displaced backwards, so it would go over the edge of the glenoid, which is the rim of the glenoid, like that. And during that, the anterior side of the humeral head, which is this, it would rub off the edge of the glenoid or the rim of the glenoid. So it would hit the rim of the glenoid, and this might lead to impaction fracture in the anterior side of the humeral head, which is called the reverse Hill-Sachs lesion. It is called the reverse Hill-Sachs lesion because, in contrast with the Hill-Sachs lesion, the Hill-Sachs lesion occurs to the posterior part of the humeral head and it occurs in the anterior shoulder dislocation. And the reverse Hill-Sachs occur in the posterior dislocation and it affects the anterior part of the humeral head. Now also during the posterior dislocation, the anterior part of the humeral head would also hit the labrum, the posterior part of the labrum, and this would lead to reverse Bankart lesion, and would also might fracture the rim of the glenoid, which is called the reverse bony Bankart lesion. So it would hit the rim of the glenoid, and this would lead to the reverse bony Bankart lesion, which is an avulsion fracture of the posterior glenoid rim. Now, what about CT scanning? So CT scanning is indicated if the patient is uncomfortable to do the main imaging techniques, and it is used also to look for other injuries other than the dislocation. Now, a very important note you should pay attention for is that the posterior shoulder dislocation is often a misdiagnosis in the emergency department. That is because physicians mostly order one shoulder view, and it is the AP shoulder x-rays, and 50% of the cases will look normal on the AB shoulder x-rays. So that is why it is a misdiagnosis in a significant number of cases. And to solve that, you need to have a high index of suspicion, and unique features of posterior shoulder dislocation include the loss of external rotation of the affected arm. So when the patient can't externally rotate their arm, try to order 2 views for the shoulder. And when you order 2 views, you would find out that there is posterior displacement on the axillary or lateral shoulder views. And as I mentioned, a high index of suspicion is important to decrease the misdiagnosis of posterior shoulder dislocations. Now let's talk about the treatment. So posterior shoulder dislocations are treated with closed reduction. Unless there is a contraindication to closed reduction, then the open reduction is done. Regarding closed reduction, it is done with sedation, and sometimes general anesthesia is used, and the patient is supine, then pulling on the arm with the shoulder adducted for a few minutes to allow the humeral head to disengage. So you put a traction on the patient arm for a few minutes until the humeral head disengages, and then the shoulder is flexed and adducted, and further internal rotation is added, and direct pressure to the humeral head from behind may be added to facilitate reduction. And once the humeral head reduces, the arm is gently rotated externally, and a neurovascular examination is done after reduction to check for vascular and nerve injuries. Now X-ray is taken to confirm reduction and exclude fractures, and if reduction feels stable, then the arm is immobilized in a sling or a collar and cuff. But if reduction feels unstable, then the shoulder is held widely abducted and laterally rotated in an airplane type of splint for 3 to 6 weeks to allow the posterior capsule to heal in the shortest position possible. And active exercises are done to regain function. Regarding open reduction, so open reduction is indicated if there is irreducible acute dislocation, so it did not reduce by the closed reduction, so now we use the open reduction to reduce it, or if there is a fracture associated with the dislocation. Now surgery is indicated in some cases of acute neurovascular compromise, and surgery is also indicated in persisting acute instability. Now regarding the treatment of the unreduced dislocation, so if the patient is young and missed dislocation is fairly recent, then open reduction is indicated, and the open reduction is done through deltopectoral approach. The shoulder is reduced and the defect is in the humeral head is treated by transferring the subscapularis tendon into the defect, and that is the McLaughlin procedure, or it can be bone grafted or the laceral porosity is transferred with the subscapularis tendon if the defect was large. And light dislocation in elderly are best left untreated, but movement is encouraged. Finally, let's talk about the complications. So, complications of the posterior shoulder dislocation include fractures of the humeral neck, also posterior glenoid rim fractures, which is the reverse bony Bankart lesions, or laceral tuberosity fractures associated with the dislocation. And complications also include recurrence, stiffness of the shoulder joint, osteoarthritis, and nerve injury, and most commonly the axillary nerve injury and adhesive capsulitis. And with that, we reach the end of this video. Thank you guys for watching. Please like this video and comment your ideas and questions. And this video is a part of a bigger class. It's called the Shoulder and Arm Trauma Masterclass. You can check it out if you want.